I'm really curious to hear what Jen and Emily have to say. I have always tended to use that analogy that there's bench to bedside and then bedside to curbside, because there's this thought that you have to take what you know about the clinical implications of a disease and then go understand what that means in the population. But I think it also is the curbside and backwards again too, because we're thinking about how where patients live impacts their health also. But I think there's a much bigger picture, kind of 30,000-foot view, that beyond the biology of a disease and what's happening in the cells and how that cancer is working in someone's body, there's so many other ways that the world around them impacts their outcomes with their cancer and how they experience cancer, as well as their survival and all, et cetera. And that is my very quick, but I see Emily nodding and I feel like you're, what would you add?
No, I think I think the other thing I would add is that, so we know there's a lot of questions that we answer in the bench, so in the lab, or kind of with smaller clinical trials that only really look at, 5 mice or a couple hundred patients, or in population health lets us look at things on a much bigger scale. Also, some research only happens at cancer centers and does not include patients that are treated out in the community. And population health tries to partly look at what the patterns are more broadly. So looking at, thousands of patients and patients at cancer centers and not at cancer centers, that can help us answer questions like, if we have this new cutting edge therapy, who are the people who get it and who are the people who don't get it? And why might there be people who don't have access to that? Or if we have all of these people who get it, as Julie said, everybody who gets that cutting edge therapy, why do some people still get sick and some people don't? And kind of answer some of those big patterns, big disparity questions that you're not necessarily going to be powered to do in some of the smaller studies.
Because then the ultimate goal would be, once you understand who doesn't have access and who isn't getting the cutting edge therapy, if that cutting edge therapy is the answer, then the next step is, how do we get it to them? And that's the kind of research that can help us figure that piece out too, is the thought.
And so for this study, helping us figure out, which kids with cancer are more likely to get COVID, and then can we think about how to help them as a community, or how do we as a community better counsel patients or help reduce the risk in those kids that are at risk of getting COVID? And then amongst those kids who are at risk of getting sicker from COVID, again, how do we counsel? How do we take better care of those kids when they do get COVID to decrease their risk of getting sick? So kind of taking those big picture risk things and trying to figure out what we can do to mitigate the risks.
Jen, you always have such a good 30,000-foot summary. What would you say?
I mean, I think specific to this study also, is part of what we've done is taken a snapshot of this moment in time that now we have the data for, so that also, as we look back and try to understand, because yes, potentially the numbers are going down, although I think we all still see COVID. But in 5 years, I think we're going to all still have questions about what the impact was. Mm-hmm. And so, we really captured, and this is what I think population sciences does, like what was happening in real life, in real time. And, how can we understand that, as we're moving forward. So, I think in the lab, there's many things that you're able to control. In population sciences, there's a lot less that you are in control of. You're really much more trying to be, descriptive and understanding, and then move forward from that.
As Jen said about down the road, just highlighting that of those kids in our registry, 45% of them, so almost half, have had their cancer therapy changed due to COVID-19. And it'll be really important as we move forward to figure out what are the long-term impacts of that. So are we going to have decreased survival in these kids who had COVID and got their cancer therapy changed? We don't know. And population health is one thing that we can use to answer those questions down the road.
And hopefully be able to prevent any, hopefully we will not be experiencing a pandemic in the same way in our careers, but if there is another one, we're at least better prepared to understand what we would need to do to prevent those problems from happening again as well, with anything along these lines, or even barely similar to it.
And you know, we say that COVID-19 rates are going down, and we also know that kids with cancer have abnormal immune systems. And so, you know, even if they get vaccinated, are they still going to be experiencing COVID because they're not going to respond normally to the vaccine? So I don't think any of us think that COVID in kids with cancer is going away anytime soon, unfortunately.
Absolutely. I think we're moving towards an acceptance that we'll vaccinate these kids and hope that they get enough of a response, but it may not be going away for them as fast as it is for everyone else.
We encourage kids with cancer to get the flu vaccine, but we always tell families the most important thing they can do is to vaccinate themselves and to keep them away from kids who are sick. And I think our data showing that these kids with cancer are getting sick and they're having their cancer therapy change really shows how important it is to protect kids with cancer from getting COVID. And so once we have approval for their age, getting the COVID vaccine themselves and really talking to families about getting the vaccine themselves, and then encouraging them to not be hanging out with people who are sick or have had recent COVID contacts or things like that. We do also hope that one of the pieces of information we're now capturing with our registry is whether or not a kid who's gotten COVID has had the COVID-19 vaccine, which will also hopefully start giving us a little bit of information about how effective the COVID vaccine is amongst these kids with cancer.
And there's some early data to suggest that patients who are immune suppressed mount a response, but maybe not as much of a response as people that aren't immune suppressed. So we're going to keep powering along in terms of trying to get them a little bit of as much coverage as we can. But like you said, treat it like the flu vaccine and really try to get the people around them covered. I think I don't think I've ever had so many vaccine discussions in my career since leaving general pediatrics. It's basically almost every room I walk into now is talking about this with parents and family members right now, and anyone that has a kid over 12.
And I think it's really helped me have conversations with parents thus far about whether or not they should get vaccines, to have some data to say, you know, your kid is one of the ones that I'm really worried about, that if your kid gets COVID, I'm worried about it. And therefore you should do whatever you can to protect them. So I think even Absolutely. The data that we have that doesn't include vaccine data has helped me and others counsel families about how important it is for them to get that COVID vaccine.
I mean, I think one of the hallmarks of pediatric therapy when you compare it to adult therapy, so my just full disclosure, my focus is on adolescent young adult research, so I kind of live in between the two. But one of the hallmarks one of the hallmark differences between the two is that pediatric therapy is really intense, and we rely on the intensity of it, and we rely on not taking breaks, and we rely on pushing through for the success rates that we've achieved, where we've got over 80% overall survival if you lump all of our cancers together. So I think there's a concern that by backing off and delaying treatment that we may be doing these patients a disservice when the research through the decades has shown that we really do need to be as aggressive and give attention to the time and pushing through as possible. So I think we don't necessarily have the data yet, of course, to show what that's going to mean for outcomes, but that's what we're all very concerned about. And one of the reasons why the Concern Foundation funding, which is so aptly named for this too, is going to enable us to be able to follow those outcomes so that we can hopefully prevent those problems in the future too. Is that fair, Emily and Jen?
Yeah. We've been looking at exactly those questions as well in our population to figure out which kids who have cancer are more likely to get sick with COVID than other kids with cancer. And just like in the general population, we have found that Hispanic children are more likely to get COVID than other children with cancer. And additionally, kids who are publicly insured are more likely to get COVID than their peers. So definitely finding the same socioeconomic and racial ethnic disparities that exist in the general population. One of the reasons we really want to expand with the help of the Concern Foundation to get more personal information is that we have very little information about where these kids are coming from. And so even just getting zip code data can give us a lot of information about urban versus rural status, and how, insurance is one indication of socioeconomic status, but with zip code, we can get a lot more information about neighborhood socioeconomic status and things like that, which I think will help us give us a little better understanding potentially of why Hispanic children and kids with public insurance are getting COVID more than their peers.
And I think exactly like Emily said, just to build on that, like as you alluded to, Megan, some of those kind of broader indicators of neighborhood deprivation and neighborhood, structure and social, the built and social environment. We know that those impact the general health outcomes in Hispanic and Latino children. And so I feel like, and in patients across the board. So with these data, we'll be able to really drill down into that, all of the above.
I feel like the data that we have has been really important and has shown these really, to me, unfortunate disparities and we need more information to figure out better exactly why they're happening so we can do something about it.
We were able to compare our cohort to the SEER data, which is the national reporting database for the registry for cancer patients. And so we've been able to, that's where those comparisons Emily was talking about, where we compared what proportion of our patients were publicly insured or were Latino or Hispanic versus the national database of SEER. But we need a lot more information before we can give you a why.
What are we going to do about it other than be upset?
Exactly.
So we have a lot of help going on with this, and a lot of it, as we said, has just been a labor of love, and that both Julie and I have other active research going on and have really kind of diverted resources to help get this off the ground. And it was not what our clinical research assistants thought they were doing, but we have a master's level statistician who has been running our reports every other week and doing the more in-depth analysis for the manuscript. She is supported by a PhD statistician who she can kind of ask questions for as needed, because it's definitely beyond Julie or my skill level to run these analyses right now. And then we also have clinical research assistants who are have graduated undergrad and are working in our research group, who have been doing all of the tracking of the IRBs and following up when sites have questions and figuring out when we need to make modifications to our data collection form, doing that, and doing all of the nuts and bolts.
Uploading the report to the website, which is not something I could do.
Yeah. And sending out an email to all the 300 people across the country who get it, and all of those pieces. So
it's been a team labor of love, though. I think for sure.
Yeah.
No, we really are grateful for the Concern Foundation, and I really do think it's very rare to find a foundation that can do such amazing detailed support at the bench and also think about population sciences in this way. So we really do appreciate you guys.